Hello and welcome to A Doctor's Diary, practical medicine for everyday clinical life. In this video, we are discussing pertussis, also known as whooping cough, a highly contagious respiratory infection that remains clinically important despite the widespread availability of vaccination. Pertussis is mainly caused by Bordetella pertussis, a small, gram-negative, encapsulated aerobic bacterium. It produces multiple toxins and virulence factors that damage the ciliated epithelium of the respiratory tract, impair local defense mechanisms, and lead to inflammation of the airway mucosa. In most cases, Bordetella pertussis is responsible for classic whooping cough, although Bordetella parapertussis and, more rarely, Bordetella homezii can cause similar illnesses that are usually milder and shorter in duration. Pertussis occurs throughout the year and does not show a strict seasonal pattern. Even in countries with high childhood vaccination rates, cyclical increases continue to occur every few years. Infants represent the most vulnerable group, especially young infants who are too young to be fully protected by vaccination. They have the highest risk of severe disease, hospitalization, complications, and death. At the same time, older children, adolescents, and adults continue to play an important role in transmission, often because immunity wanes over time after both vaccination and natural infection. Humans are the primary reservoir for Bordetella pertussis. Transmission occurs through respiratory droplets during close contact, usually within about 1 meter, through coughing, sneezing, or speaking. Adolescents and adults are particularly important as sources of infection for infants because the disease in older age groups is often overlooked. The incubation period is usually around 9 to 10 days, but can range from approximately 6 to 20 days. Infectiousness typically begins near the end of the incubation period, reaches its peak during the first 2 weeks of illness, and may continue for up to 3 weeks. When appropriate antibiotic treatment is started, the duration of contagiousness becomes significantly shorter. Pertussis can last for many weeks and sometimes even months. In unvaccinated individuals, the classic disease typically progresses through 3 stages. The first stage, known as the catarrhal phase, usually lasts 1 to 2 weeks and resembles a common cold, with runny nose, mild cough, and little or no fever. This stage is followed by the paroxysmal phase, which may last 4 to 6 weeks and is characterized by repeated coughing fits, often followed by a forceful inspiratory gasp or whoop. These attacks may be associated with thick mucus production and vomiting. These episodes are often followed by worsening symptoms during the night. The final stage, known as the recovery phase, involves gradual reduction of coughing episodes, although symptoms may persist for several additional weeks. In adolescents, adults, and many vaccinated children, pertussis often presents differently. The disease may appear simply as a persistent cough lasting more than 2 weeks, sometimes without the typical inspiratory sound or vomiting. In infants, the disease may also present atypically, and episodes of apnea may be more prominent than cough. This is particularly important because young infants are at highest risk. Complications of pertussis include pneumonia, which is often caused by secondary bacterial infection, as well as otitis media and sinusitis, rib fractures, hernias, subconjunctival hemorrhage, and, in rare cases, neurological complications such as seizures or encephalopathy. In very young infants, severe leukocytosis, hypoxemia, and pulmonary hypertension may occur and can be life-threatening. Because the clinical presentation is often atypical, especially in older children and adults, laboratory diagnosis plays a crucial role. Pertussis should be considered in patients with cough, particularly when typical symptoms are present or when cough persists for more than 2 weeks. Previous vaccination does not exclude the diagnosis. In the first 2 to 3 weeks after the onset of cough, the preferred diagnostic methods are PCR or culture from properly collected nasopharyngeal samples. PCR is rapid and highly sensitive and is especially useful in vaccinated individuals, adolescents, and adults. Serology becomes more useful later in the illness, usually after about 2 weeks, although interpretation may be influenced by recent vaccination. Antibiotic therapy is most effective when started early, ideally before the onset of the paroxysmal coughing stage. Even when started later, antibiotic treatment remains important because it reduces transmission and helps interrupt chains of infection. Macrolide antibiotics such as azithromycin and clarithromycin are commonly used. Cotrimoxazole may be used as an alternative in selected cases. Prevention remains the cornerstone of pertussis control. Protection depends not only on primary childhood vaccination, but also on booster doses later in life. One of the most important preventive strategies is vaccination during pregnancy, allowing protective antibodies to be transferred to the newborn. In cases of confirmed pertussis, infection control measures are essential. Patients who are hospitalized should be isolated for several days after starting effective antibiotic therapy. In community settings, temporary exclusion from schools or childcare facilities may be necessary until the individual is no longer considered infectious. Although pertussis is a vaccine-preventable disease, it continues to circulate. Awareness, timely diagnosis, and consistent vaccination remain essential in everyday clinical practice. If you found this explanation helpful, consider following for more clear and practical medical content designed for everyday clinical practice. Medicine is learned from books, but real understanding comes from shared experience. Thank you for watching, and I'll see you in the next entry.